Are people able to hear? Is anyone able to just put something in the chat? Okay, so can everyone hear me? Right, we'll just crack on. So I'm Saeed. I'm I'm a current F2 at St. Peter's in Surrey. So today I want to do a talk on the vertebral column and essentially just a little bit about the associated conditions that can arise from basically abnormalities of the vertebral column and the spinal cord, and just kind of a quick whistle-stop tour, really. So when it comes to the vertebral column, there's many things you can discuss. So you have spine, kind of the whole principles of the spine, the anatomy of the spine. Then you have kind of things like cord Aquinas syndrome, spinal cord compression, degenerative disc disease, spinal fractures, infections as well, spinal abnormalities. There's so many things that are basically going on with the spine that you could talk about the spine pretty much all day and still not even cover that much, actually. So when we say spine principles, what exactly do we mean? So this is where essentially things can get slightly more complex. So the reason why I've included this in is if you think about the brain, for example, and there's the whole concept of the Monroe-Kelly doctrine. Essentially, the equivalent in the spine is known as the Punjabi and White framework. Basically, it's a framework to understand spine stability. So, for doctors when they're ordering scans, when people have come in after major trauma, and the radiologist makes a comment or the neurosurgeons make a comment about stability, spine instability, and stuff like that. A lot of it has to do with kind of this framework. So essentially, it's something that was devised in the 70s and 80s, where basically it talks about the ability to the spine rather to limit patterns of displacement so that you're not damaging or irritating the spinal cord or the nerve roots rather, and also to prevent any incapacitating deformities or pain due to structural changes. So put it like this: if you were to put a huge piano on somebody's back, it's why does the vertebral column and spinal cord not just collapse? Well, it's to do with these principles. And there's another subclassification that they talked about, which was these three subsystems. So you have an active subsystem of the spine, you have a passive subsystem of the spine, and you have the neural control subsystem. Essentially, it's a description of three different parts of three different systems. Your active system is important when you're talking about your muscles, your tendons, particularly your core. And I think it's something that's very neglected when it comes to back pain. So you see lots of people come in with debilitating chronic back pain. And one of the things that's often missed quite a lot in patients presenting with back pain, whether it's to the emergency department or even the GP, is actually their core muscle strength, because it holds a huge amount and contributes a huge amount to the overall stability of the spine. You have the second subsystem, which is your passive subsystem, which is basically your osteoligamentous system. So we're talking about your bones, so your vertebral column, your 33 segments, your tendons, so your kind of all the tendons and ligaments that run in the back. And lastly, you have your neural control subsystem, which is basically your central nervous system, which is your spinal cord, your peripheral nervous system, which is obviously, where you have the chordae equina and things distal to that. And essentially, it's a well-tuned balance. And essentially, when people have back pain, or let's say they have spine instability because of major trauma to the back, they've had a road traffic accident, if they have an unstable spine, it means that one of these subsystems has failed, and essentially now it cannot compensate. And so they're left with one of these things, which could be deformity, it could be severe incapacitating pain, or even focal neurology. So in terms of the functions of the spine, there's 4 overarching growth functions that you have. So obviously, number 1 is protection. So it's protecting possibly the most vital part of your body, which is your spinal cord. Your spinal cord is enclosed in the vertebral column and ends at the L1, L2 vertebra. It also is there to support the weight of the body. So when you think about it, it's how much weight is it actually carrying? It's carrying a lot. It also forms a axis, so it's actually the central axis of the body. So it connects your peripheral musculature to the core of the body. So your limbs are all connected via the spine. And the last function is movement. So it has a huge role in movement, posture, which is, when you think about it, when patients come in because of back pain and they're admitted, for example, a lot of the time they're having issues with posture, so they're lying flat in bed because of the pain. They cannot move. So it just shows you how much the back has a role in actual, let's say, a patient's posture and movement. When a patient has really bad back pain, their movement is going to be compromised. Their posture will be compromised. So in terms of the anatomy, you can't really go much further into the vertebral column and spinal cord and all the conditions associated with it without at least having a very quick glance over the anatomy. So this is a really nice picture of one vertebral segment. So essentially, the vertebral column is a system of 33 bones, which we call vertebrae, and they are stacked on top of one another. And they are separated by discs, which are basically kind of fibrocartilaginous structures that sit between these vertebrae. The column can then be divided into 5 different regions, which we'll talk about quite briefly. And each vertebral structure, or rather each vertebral segment, has a different anatomy. So what do you mean by that? So essentially, this is your overarching anatomy. So as you can see, this is your vertebral body. That's your vertebral arch. So what you have here, this red part is your transverse process. Then you have the pedicles. The reason why it's important, especially to identify the pedicles, is actually when we think about spine surgery, a lot of the time, the places where we're putting screws is in the pedicles. So you'll often hear the term pedicle screws or posterior instrumentation. This is the area where we would usually put screws in. You then have the lamina, which is basically connecting your spinous process to your transverse process. And the lamina is another important part of anatomy, because when we talk about laminectomies, specifically, let's say decompressions, when you're decompressing the spine because of, let's say, chordae equina syndrome, essentially when we mean decompression, we'll mean a laminectomy, which means essentially we just remove this portion of the vertebral column, and essentially that's removed, and then it allows the spinal cord, or the spinal nerves rather, to to breathe more freely. Your spinous process is this orange segment here, which you can actually palpate if you touch your back, and that's the most. That's basically the most palpable part of your spine. And actually, this is a picture of the lumbar vertebra. So starting off from the top, you have the cervical vertebra. So when it comes to your cervical vertebra, you have 7 of them. And essentially, the top 1 and the top 2, so C1 and C2, are named the atlas and axis respectively. And they are very, very specialized vertebrae that allow for movement of the head, basically allows for your neck and your head to sit on your vertebral column and act as a kind of let's say a supporting structure to allow you to actually flex and extend your neck, but also rotate it, which is obviously a really important part of your daily function. So let's say you're operating on somebody and somebody's coming with a broken neck. A lot of the times you need to be able to, when you're opening up and dissecting, you need to know what you're looking at, and you're not going to have the luxury of basically having a diagram next to you. So you need to know the certain things that you should be looking for. And one of the things that you need to know is the fact that the cervical vertebra often have bifid spinous processes. So all that means is that it kind of dissects into 2. So usually you'll have 1, just like we had here. But in a cervical vertebra, a lot of the time they are bifid, and that's not always the case. So sometimes C1 actually doesn't have a spinous process, and actually C7 may not even have, may have a really long spinous process. So the anatomy is always different, but on the whole, if you're doing, let's say, the MRCS and they're talking about a bifid spinous process, you would typically associate that with the cervical vertebra. The second distinguishing feature is your transverse foramina. This is an opening in each of these transverse foramen. This allows for the vertebral arteries to travel through to the brain. So this is a really, really important structure. And this is actually one of the things that when you are operating on somebody's neck, it's one of the things that you will probably look for first. You want to identify where you are by looking laterally to see where your vertebral arteries are. Lastly, you get a triangular vertebral foramen, which is a bit different to some of the other vertebrae, which are circular. So that's your cervical vertebra. You have 7 of them, and they have 3 distinguishing features. They have a bifid spinous process, they have a triangular vertebral foramen, and they have a transverse foramen, which allows for the passage of the vertebral arteries through to the brain. Your thoracic vertebra, essentially you have 12 of them, and they form a bony cage. So it's very important because they articulate with the ribs. And that bony cage is your bony thorax, and essentially protects a number of important structures in your mediastinum, obviously your heart, your esophagus. There's so many vital structures held in that thoracic cage. When you look closely, and if you're ever, doing a surgical exam and you're given this vertebra, one of the things that you should always look for to see whether it's a thoracic vertebra is to see if it's got these demifacets. So these demifacets, you can see one superior and one inferior. And these are there to articulate with the ribs. So you get 2 different ribs articulating with these demifacets. Another thing you get is on the transverse process. So right towards the back, posteriorly, you have these costal facets. And this is once again also there to articulate with the shaft of a single rib. So the thoracic vertebra is very ergonomically designed actually to match up with your ribs. And so you can see actually anatomically how smart the thoracic vertebrae are in terms of the development, because they allow for the very simple articulation with the ribs. And lastly, this is not a triangular foramen, it will be circular. So once again, if you're given a vertebra and you're asked to identify what one this is, if it's circular, it's most definitely not going to be your cervical vertebra. It's most likely your thoracic or even your lumbar. Moving on to the lumbar vertebra, this is a really nice picture that we've talked about. So you've got your transverse process, you have your you have your lamina, you have your superior articular process, and you have your pedicles over here. As you can see, the body over here almost looks like a kidney. So you can say that it's kidney shaped, and actually your lumbar vertebra have the largest vertebral bodies because of the fact that they essentially are going to be holding the most weight. So your lumbar vertebra is a lot more flexible than your thoracic vertebra per se. And so they need to be able to hold a lot more weight, and hence why it's quite a big surface here actually, because it's going to be holding a lot more weight. Another thing with the lumbar vertebra is that you have 5 of them, and essentially they lack the other characteristic features. So you're not going to have costal facets, you're not going to have a bifid spinous process, and you're not going to have transverse foramina. Unlike the cervical vertebra, they also have a triangular shaped vertebral foramen. So this is one way that you can identify the lumbar vertebra. Another thing about the lumbar vertebra is that it's designed in a way that allows for us actually to tap it quite easily. So because of how big it is and its orientation, it's not like the thoracic vertebra, which kind of are going in a posterior and oblique direction. It allows you to actually put a needle into the lumbar spine and actually drain out CSF. So it's designed in a way that allows us to utilize it. Lastly, you have your sacral and coccygeal vertebrae. So they are right at the bottom, or kind of the caudal tail end of the vertebral column. And these are fused. So sometimes they might be called false vertebrae just because they're not separate segments. Your sacrum is 5 fused vertebrae, and it almost looks like an inverted triangle, and essentially it forms the back wall of your bony pelvis. So on the lateral walls, you are articulating with the sacrum. The sacrum is going to then meet with the iliac bones to form what is your bony pelvis. The coccyx is 4 fused vertebrae, and it's a very small bone, and actually they don't even have a vertebral canal. So they are almost not really even classified as vertebra. Hence why we call them false vertebra. One of the terms you might sometimes hear, particularly if you're doing an orthopedic firm or something and you're spending some time with spine surgeons, is kind of lumbarization and sacralization. And that's basically, if you have S1 and it's kind of separated and joined your lumbar spine, that's called lumbarization, because your sacrum is now kind of going into your lumbar vertebra. Whereas if you have an L5 vertebra that's connecting to your sacrum, that's called sacralization, because essentially it's now kind of fusing into your sacrum, really. So those are just 2 words to be aware of. The last thing to do with anatomy is the vertebral joints and ligaments. So your vertebral column is held together very tightly with different joints and different ligaments. So the joints that you have are your articular facets, and they basically allow for your for one vertebral body to articulate with another vertebral body in the vertical direction. Another thing that you have are these ligaments. So right posteriorly is you have your supraspinous ligament. You then have your interspinal ligament, which sits between your vertebral arches. You then have your ligamentum flavum, and then you have your posterior and anterior longitudinal ligaments. These are 2 really important ligaments. So your anterior longitudinal ligament is very, very thick, and it's there to prevent hyperextension injuries. Your posterior longitudinal ligament is a lot weak and prevents hyperflexion. That kind of actually explains as to why we can flex a lot more than we actually extend. So last thing is spinal deformity. So kyphosis is kind of what is colloquially known as a hunchback. So it's the excessive thoracic curvature that you can see here. And lordosis is typically in the lumbar region, and you can see it's when it causes this kind of sway back deformity. So it's kind of concave. Essentially what can happen is that you're naturally going to have some kyphosis and lordosis to allow for the optimum movement of the spine. What can happen sometimes is patients have issues with that, so they can get excessive kyphosis, excessive lordosis, and actually sometimes they can even get scoliosis, which is this lateral curvature of the spine. It's usually due to an unknown cause, and a lot of the time is congenital, and may or may not need fixation, depending on how bad the lateral curvature is. So now we're going to move on to Cordy-Quiner syndrome. So Cordy-Quiner syndrome is classically one of the most important things that you're always taught in medical school, if you're, in the emergency department. So what happens is that your Cordy-Quiner is basically a Latin word for the horse's tail, because as you can see here, it's almost quite messy. It almost looks like if you had the strings of a violin and you tore it apart and it all just flung out. That's pretty much how it looks like, actually. And it's a huge collection of spinal nerves. So it's not your spinal cord, it's spinal nerves. So it's distal to your last part of the spinal cord. So you can see here, this is your spinal cord. It's ending here at something we call the conus medullaris, and distal to that, these are all spinal nerves. So this is your peripheral nervous system. So this is your Cordy-Quiner. So essentially, when you compress this, you're going to get a syndrome known as Cordy-Quiner syndrome that is characterized by lower limb weakness, severe lower back pain or sciatica pain, as well as abnormal perianal sensation. That's kind of the three things you always look out for. In terms of the anatomy, we've already spoken a little bit about anatomy, but your spinal cord begins at the medulla oblongata, which is right at the bottom of your brainstem. So you have your midbrain, your pons, and your medulla. Your medulla is the final part of the brain and basically the most superior portion of the spinal cord. It comes down the spinal cord, and your spinal cord ends, or rather, it comes down your vertebral column, and your spinal cord ends at the level of the L1, L2 vertebra. And there are 31 spinal cord segments as opposed to 33 vertebral bones. So your Cordy-Quiner is, like we've just talked about, it's distal to the last part of your spinal cord. So it's a collection of spinal nerves. It's not your spinal cord, the Cordy-Quiner, but it's still a very, very, very important structure that allows for the innervation of your lower extremities, your perianal sensation, and parasympathetic sensation. So using that logic, if the Cordy-Quiner is important for, let's say, lower limb motor movements or your perianal sensation, or let's say control of the sphincters, it's no wonder as to why, if you have compression of your Cordy-Quiner, you are going to have issues with the parasympathetic sensation. So, you're going to get tingling and numbness around your groin. You are going to have weakness in the leg. So when you're doing a lower limb neurological examination, it's not going to be MRC grade 5 out of 5. In fact, it may drop to 4 or 3 or even lower than that. That's a good way of thinking, actually, about what the Cordy-Quiner, what its function is. It's very rare. So almost every single case of back pain that you see as a doctor, particularly in the emergency setting, the first thing you always want to do is exclude Cordy-Quiner syndrome. When it's exceedingly rare, and in fact, looking at a few studies, was mentioning that actually some primary care practitioners may never even see a case of Cordy-Quiner because it's just that rare. It only accounts actually for about 2 to 6% of lumbar disc operations. So if you think about all the things that we do for the lumbar region, operations-wise, so discectomies or kind of, let's say, pharamnotomies and microdiscectomies and all these kind of things, only 2 to 6% of it is actually for Cordy-Quiner. So it just shows you how rare that it actually is. So any narrowing of your spinal canal at the level of the Cordy-Quiner, which is, remember, below the spinal cord, is below N1, L2, any narrowing there can cause Cordy-Quiner syndrome. So what kind of things can cause Cordy-Quiner syndrome? The most common is a slip disc, or as we call degenerative disc disease. So it's herniation of the spinal disc, most commonly at L4-L5 or L5-S1. So a slip disc, particularly, let's say, at the level of the Cordy-Quiner, so below L1, L2, can cause Cordy-Quiner syndrome if it presses onto the Cordy-Quiner. Other things are things such as spinal trauma, so vertebral fractures, So if you have a fracture, let's say distal to L1, L2, that you've got fractured end plate, or your bony segments have retropulsed and then are pressing on your corda equina, that could be really dangerous and cause corda equina syndrome. So trauma is always an important one to, yes, look out and do x-rays for fractures, but actually to do an MRI to see if there's any corda equina. Infections as well, so kind of a big abscess, Pott's disease, which is TB of the spine, or discitis, which is kind of a localized infection of an intervertebral disc. These can all cause corda equina syndrome. In terms of the clinical features, it's characterized essentially by, like we mentioned, low back pain. It's typically really severe low back pain. So they have that in addition to leg weakness. So their lower limb motor movements are drastically reduced. So that's why it's always good practice to do a full peripheral nerve examination. So you should be testing the function of the lower limb motor movements, and you should be documenting a full Asia chart, which is basically a chart that we use particularly in neurosurgery or orthopedics or even emergency department to document the findings of an examination. So if it's grade 5, you'll document on the Asia chart that this patient's motor movements is grade 5 or below that. In addition to back pain and focal neurology and kind of the Asia chart we've talked about, they can get saddle anesthesia. So what exactly is saddle anesthesia? So saddle anesthesia is basically, if you think about if you were sitting on a horse, the part of your body that's sitting on the horse, on the saddle, that part of the body that's making contact with the saddle is essentially what we call the saddle region, and that's where you get anesthesia. So it's your sacral dermatomes, and I'll show you a picture actually. But this is where you get saddle anesthesia, so around your groin. And you get either reduced or absent sensation around the perineal skin. So really good practice is actually when you're going and doing a neurological examination is actually to have a kind of like a metal pin, the ones that you use in a neurological examination, and actually when you're doing a PR, or let's say after a PR exam has been done, it's good practice to use the this kind of pinprick pin to feel the dermatomes, particularly S3, S4, S5, and see if there is any reduced or absent sensation around the perineal skin. You can also ask if they're having tingling or numbness around that region. Other clinical features are blood and bowel dysfunction. So remember we talked about the corda equina being really important to do with the parasympathetic nervous system. So your parasympathetics usually are there to allow you to basically to micturate. So your sympathetic, remember if you're in a fight or flight situation, you don't really want to go for a wee. When your parasympathetics, it's your rest and digest. It wants you to basically empty your bladder. If you've got damage to your parasympathetics, then you can't empty your bladder, and then you're left with urinary retention. And that's why I call it equina. One of the things we always look out for is urinary retention, and that's why we always do pulse fluid bladder scans, and we're looking at the pulse fluid residuals, how much urine is left in the bladder, to see whether they're having problems with retention and with micturition. And another thing as well, in addition to that, is the sciatica back pain. So in addition to the back pain, they may complain of shooting pain down the leg. Usually it's asymmetrical, unilateral. In certain cases, it can also be bilateral, but typically you would see it in one leg. But if you did see bilateral, that should probably set alarm bells ringing, and you probably want to expedite this person's MRI, or you'd at least want to really make sure that they have a scan as soon as possible. In terms of the symptoms, so like we talked about, you're going to get back pain and sciatica pain. So that's kind of your first symptom. It's just pain in the lower portion of the body. Number 2, saddle anesthesia. Number 3, blood and bowel dysfunction. It's a good, quick way of thinking about it. In terms of signs, so remember we talked about the corda equina actually being distal to the spinal cord. That means that it's a peripheral nervous system lesion. So if you have a lesion to your peripheral nervous system, it's characteristically a lower motor neuron lesion. So that means you're going to get lower motor neuron signs. So those are things like hypotonia, hyporeflexia, leg weakness, and leg sensory changes. So like we're talking about abnormal sensation, it may not just be in the groin and the perianal region, and you may not just have perianal or saddle anesthesia. You may actually have sensory changes along the single dermatome as well. Another thing that's really important is that a lot of the time, particularly if you're taking a referral for this, is that people oftentimes will tell you, oh, there is reduced anal tone. Remember, when you're doing a PR exam, you either have anal tone or you have loss of anal tone. You don't really have reduced anal tone. You have it or you don't. So a good way of saying it would be there is, anal tone is intact, or you say there's loss of anal tone. That's better practice than to say there is reduced anal tone, because there's not really any such thing as reduced. It's either there or it's not. Another thing you may get is palpable bladder. So like we talked about, if you're having difficulties with actually passing urine and you have urinary retention, you may be able to palpate the bladder and may have a full bladder with over 500 to 1,000 mils left in the bladder. So you have different classifications of cauda equina syndrome. So you have cauda equina syndrome with retention, which is kind of the most severe, because that's where you have your back pain with unilateral bilateral sciatica, you have low limb weakness, you have sensory disturbances, particularly in the saddle region, you have loss of anal tone, and you have complete loss of urinary control. So that's typically quite an end stage sign, and it's telling you that actually, this is quite a progressive lesion and things are only getting worse. Whereas if you have incomplete or suspected cauda equina syndrome, that's at a stage where actually you may have severe back and leg pains, and you may have some neurological symptoms, and you may have some suggestion of sphincter disturbance, but it's not yet progressed to the full retention episode. And that's quite important, actually, because if a surgeon is working somebody up for a cauda equina decompression, they would want to know a lot of the times actually at what stage are they with their cauda equina. Are they in retention? Are they at a point where they actually only have some urinary symptoms, or are they at a point where basically they could potentially become tetraplegic because they just have full cauda equina syndrome with retention? So in terms of the differentials, we've talked about it a little bit already, but cauda equina is a lower motor neuron pattern of weakness because it's your peripheral nervous system. Your conus medullaris is basically the last part of your spinal cord, so it can sometimes give quite an interesting mixed picture because it's at the junction between your central nervous system, which is your spine, or your spinal cord, and your peripheral nervous system, which is your cauda equina. Sometimes you can get a mixed picture. Cord compression essentially is an upper motor neuron lesion, and essentially causes an upper motor neuron weakness. And cord compression is compression of the spinal cord, so that's going to be anything at the level of L1, L2 or above. So these are your differentials. So spinal cord, once again, you'll be thinking about an upper motor neuron, cauda equina, typically a low motor neuron weakness, and conus medullaris, typically a mixed picture. One thing that can sometimes complicate the overall picture is that actually in acute spinal cord compression, you may actually have a low motor neuron pattern of weakness. So that's when things can become quite complex. But the main thing is you should do a good and full neurological examination and document all your findings. In terms of the diagnosis, you should typically always get an MRI spine. It's the most sensitive diagnostic imaging modality for cauda equina because it allows you to see the soft tissues and allows you to see the nerves in much better detail than a CT would. CT is particularly good in things like your bone injury. So if you're, someone's coming with a traumatic injury, or you're querying kind of C-spine injuries and fractures of the thoracolumbar spine, CTs are good for that. But if you're querying cauda equina, it should be an MRI. Typically, this should be done within 24 hours of presentation. And if it's actually, a high likelihood of cauda equina, then these a lot of the time can be done out of hours. And then if it is cauda equina, that's kind of when we move on to the next thing, and that's essentially where you would need to operate out of hours. So this is a nice picture of cauda equina syndrome. So you can actually see here, this is CES, that's secondary to posterior epidural abscess. So it's kind of pressing over here and causing lots of localized inflammation It's pressing on the nerves, causing compression of the spinal nerves. That's essential for your parasympathetic innervation, your perianal sensation. And basically, this person would be having a full-blown episode of lower back pain, sudden anesthesia, urinary retention. In terms of the management, so caudal syndrome is a neurosurgical emergency or an orthopedic emergency, depending on which department you're in. You should typically always go to the neurosurgeon, the orthopedic surgeons, with the view of them doing a decompression, and it should be done as soon as possible. The overarching goal of doing a caudal syndrome decompression is, number one, you want to improve the space within the spinal cord or the vertebral column and allow the nerves to breathe and allow the swelling to actually expand. And you also may want to remove the agent that's leading to the compression. And that could be particularly, let's say, spinal metastasis. That could be a primary tumor of the spine. It could be lots of things. And like I mentioned here, any evidence of bladder dysfunction is usually a very immediate indication for surgery. So bladder and bowel dysfunction is really a poor indicator in caudal syndrome, and it should always be one of the most important things that you're asking when a patient comes in. In terms of the complications, caudal syndrome causes a whole range of complications, and it's just truly one of the most debilitating conditions that a person can have. Because when you think about it, if a person is now incapacitated and they can't move and they're in permanent paralysis, not only are they going to have complete paralysis of the spine, but essentially they're going to get lots of blood and bowel dysfunction, so long-term urinary incontinence, or let's say bowel incontinence. They're going to have a lack of control over when they want to open the bowels because the sphincters are just completely not working. They'll get sexual dysfunction, so a lot of the time these patients can't really maintain an erection, and they have impotence, and that can have a really, really devastating effect on their long-term quality of life. A lot of the time they can get really complex chronic pain syndromes. So not only are they lying flat in bed, but oftentimes they are just writhing around in pain, which itself leads to all sorts of other kind of complications. So they're overusing opioids, and then they become more constipated, and they become kind of bowel obstructed, and then they go into they get a surgical abdomen. And there's so many complications that can occur from caudal. And hence why it's so important that, as clinicians or as doctors, particularly in the acute setting or even the primary care setting, that you always really have a low threshold for imaging, particularly for an MRI. So that's that. I'll very quickly skim over spinal cord compression as well. So spinal cord compression is a whole different beast altogether to caudal syndrome. So spinal cord compression, so remember we talked about the anatomy. The spinal cord is going to run from the top of the brain down to the L1, L2 vertebra. So if that's the case, that means anything above L1, L2 will be classified as spinal cord compression, and it most likely is going to happen in the thoracic region. Spinal cord compression a lot of the time is due to metastatic lesions, and actually in a lot of cases, actually 20% of cases of, let's say, malignant cord compression, a lot of the time it's actually the first presentation of underlying cancer. So spinal cord compression, or let's say metastatic spinal cord compression, is not only a neurosurgical emergency, but actually a oncological emergency. And typically these patients need urgent AOS input, which is acute oncology services, because in these patients, it may be a primary tumor, most likely will be a secondary tumor that's affecting the spinal cord. So if you look at this picture here, actually you can see this collapsed vertebral body. It's got that classic kind of wedge look to it. And actually what you see here is all of this edema that it's released because of cytotoxic and vasogenic edema. And that's pressing on the spinal cord. And that's causing what we say indentation of the thecal sac. So you can see here, it's indenting the thecal sac. And all that edema is now impacting the spinal cord and basically causing spinal cord compression. And you can actually even see here, there is a lack of CSF flow in this area because of the compression. So when it comes to spinal cord compression, there's some very classic culprits. So it's typically your breast, your lung, your thyroid, your kidney, and your prostate cancers that cause spinal cord compression. So why do those specific cancers cause spinal cord compression? Well, the reason is amongst a few different things, whether that's kind of arterial seeding or tumor spread. But essentially, you have a very interesting venous system in your body that's called the Batson's venous plexus. The Batson's venous plexus is a venous plexus that basically lacks valves like other venous systems do. So it's a valveless system. That means you have bidirectional flow between your two venous systems, and essentially because you don't have valves, it's like a highway. So the valves that are draining, let's say your prostate, they are going directly into the spinal cord or into the vertebral column. So basically, they have a whole highway into the spine, and it makes it so easy, basically, for the spread of malignant cells to be facilitated to the spinal cord, and hence why a lot of the time, cancers metastasize to the spine quite favorably because of this system called the Batson's venous plexus. So how does this facilitate cancer spread? So because you've now gone to the spinal cord, that can now go to the brain as well. So a lot of the time you're going to get brain mets, and that's a whole different beast in itself. But that's simply why you see spinal cord compression a lot in prostate and breast cancer as well. It's to do with the Batson's venous plexus. And essentially, they're bypassing the liver and the lungs, so they don't have a portal or systemic venous system. So it's not passing through any valves. It's just like a skip metastasis. It's just going straight to the spine. And you can imagine how problematic that is. And this is a really nice picture actually showing how that occurs. And you can see it's kind of just going straight to the spinal cord. So in terms of the management of spinal cord compression, there's typically three key principles, and that's your general measures. That is your glucocorticoids, so your corticosteroids, so your prednisolone, and also your definitive procedures. So that's going to be surgical options. So the first thing is general measures. So remember, these patients, a lot of the time in spinal cord compression, the primary complaint a lot of the time will be severe back pain, more so than in cord equina. And essentially, because these people are going to be so incapacitated by the pain and mobility, not only is VTE prophylaxis a huge part of the management here, but actually, these patients need a pain team review as soon as possible, and actually an oncological review as soon as possible. So these are the metastatic spinal cord compression guidelines. And essentially, if somebody's come in and you're querying spinal cord compression, so they've got an acute spine and you've worked them up and they have a cancer, these patients should be commenced on dexamethasone rather than pred. And the reason we use dexamethasone is because the aim is for it to reduce all of that edema that's pressing and causing compression. So a lot of the time, patients give 16 milligrams, that's the max dose. That is quite a huge dose, actually. And some people split it into kind of 8 milligrams BD. And this must also always be given with PPI cover because you're giving them a huge dose of steroids. And that itself is going to cause huge problems in itself and gastric ulcers and all sorts of systemic symptoms. It's really, really important you take that into consideration and actually prescribe a reducing regimen. So why does dexamethasone work so well in metastatic spinal cord compression? Well, remember we talked about the spinal cord. If it's compressed, essentially one of the things you're compressing is the venous outflow. And if you're compressing venous outflow, you're going to get lots and lots of congestion, hypoxia, and you're breaking down that spinal cord blood barrier. And what that's going to cause is cytotoxic edema and vasogenic edema. So there's different types of edema. And cytotoxic edema is basically when you get damage to the cells and pump failure of your sodium-potassium pump. And that's going to release lots and lots of edema, and it's going to also compress your spinal cord. Vasogenic edema is because you've had increased vascular permeability. So now the spaces have opened up, your membrane channels are a lot more porous and will allow for the leakage of edema basically to compress the spinal cord and cause spinal cord compression. And dexamethasone works really, really well at reducing inflammation and actually reducing all of that edema, and hence why that's typically the medical drug of choice in spinal cord compression. In terms of definitive procedures, you have it's kind of a three-tiered approach. So you have surgery, you have radiotherapy, and you have spinal support systems. These are your spinal support systems, so you can have kind of different TLSL braces or cervical, thoracic, lumbar, orthotic braces. These are typically needed when someone's got quite an unstable spine or they need to be immobilized in a rigid vest. These are quite poorly tolerated by patients, and so you wouldn't always see this, but this is one option that you can have in spinal cord compression to basically prevent movement of the spine and cause any further spinal cord damage. The second thing you can do is radiotherapy. So the different types of radiotherapy, so you have EBR, which is external beam radiotherapy, you have stereotactic body radiotherapy, and these are all different types of radiotherapy that basically target the foci of tumor on the spinal cord. So external beam radiotherapy is, very well tolerated. It's got good local tumor control, good pain relief. And you also have stereotactic body radiotherapy, which basically is, let's say, the option you'd use if, there's a radio-resistant neoplasm and external beam radiotherapy hasn't worked. But these are quite strong things to do. And a lot of the time, these things can be palliative. So maybe palliative radiotherapy, basically to ease with the pain. But these are things that you could essentially do. And the precision differs between both. So stereotactic radiotherapy has a very, very high precision. And that's where you see kind of the head being immobilized in a Mayfield clamp, because it's just so accurate and it blasts through your brain tissue or through your spine tissue as well. And hence you need to be really, really focused with where you're delivering that radiotherapy. So these are some options or kind of types of external beam radiotherapy. Now coming on to the surgical intervention, this is the last thing we'll talk about. So you have surgical decompression and reconstruction, you have vertebroplasties, and you have kyphoplasties. Vertebroplasties and kyphoplasties are basically things that interventional radiologists do. So that's basically when they put in a catheter into the spine and they basically blow up a balloon, or they fill it with cement. And essentially the aim is to restore the height of the collapsed vertebra, and that's there to kind of ease pain, ease the compression of the spinal cord. And a lot of the time, it's quite a good option, particularly in patients that aren't fit enough for surgery. And like I said, it's basically this catheter going into the spine, done under fluoroscopic guidance. And then they inflate a balloon, or they can even combine it with cement, and that restores the height, and that's typically quite a nice procedure actually. And the last thing I want to talk about is surgical decompression. So just to finish up, I've got some images here. So this is typically how you do, let's say, a lumbar decompression. So these are the things you kind of do when you need a decompression of the spine. So it's not, the lumbar region, remember, L1, L2, that's where the spinal cord ends. But this is your overarching kind of surgical technique that you would do. So you make a surgical incision, roughly a 1-inch incision. It depends kind of how much of the spine you need to access. This is the view you get. So remember, this is your lamina that we talked about at the beginning of the lecture. So over here, you're going to draw, you're going to drill 2 cuts here. And here's your high-speed drill. So you're going to cut there, and you're going to cut there exactly where these green lines are made. And there you go. That's now been cut. We're then going to use this tool, which is kind of like a curette. It's essentially what you curette, and it's there to kind of peel away all this thickened ligamentum flavum, all this hypertrophy of the ligamentum flavum. And once you kind of use the curette to usher it away or kind of pucker it away, you're then left with this. And this is now you're just ligamentum flavum. You're still pressing over here on your spinal cord, But essentially what's now happened is that you can use something called a pituitary, or kind of like a rongeur. So this is a surgical tool. It's like crocodile clips. You can basically take little bites of your thickened ligamentum flavum, pick away at it, and then eventually you allow for your spinal cord to breathe. And now you can see here, how much better is that? So once that's been decompressed, the nerves are now decompressed. The patient should now be having relief of symptoms. And this is how it looked before, and this is how it looks after. And this is the last slide. So essentially, these are the kind of options you can get. So we talked about laminectomies, that's what we just talked about. You can get discectomies, which is also when you kind of remove parts of the disc. And you can also have kind of foraminotomies, which is to make that foramen bigger. And once again, that could be done to relieve pressure in the spine because of a slipped disc. But those are kind of a number of the options that we have. And so that's it. That's pretty much kind of a whistle-stop tour of the vertebral column, the spinal cord, called the Aquinas syndrome. So it can get quite complex, but we'll try to keep it nice and simple today, because essentially it's a huge topic and it can get quite intricate and quite complex, but the basics are the basics, and it's always good for us to know at least the basic management and kind of the things that we could do. And so called Equina, we kind of talked about some of the clinical features, we talked about the management, we've talked about spinal cord decompression, we talked about some of the cancers that can cause it, and we also had a nice little introduction to the vertebral column. So now anybody that's doing kind of a surgical exam, whether it's CMLCS or anything else, any kind of Viva or OSCE, you should kind of know now how to identify different vertebrae by just how they look. And that's pretty much it. That's an overview of spine. And in the next lecture, we'll be talking about hydrocephalus. So we'll be talking about the ventricles, once again doing a kind of introduction to the ventricles, talking about some of the conditions that we can get, so basically acute hydrocephalus, and then we will finish off with 2 more neurosurgery lectures after that, and that will conclude this mini neurosurgery series on Mind the Bleep. So I hope that was useful. Feel free to leave any questions in the chat. Happy to answer them. Happy for you to email me so that I can kind of, if there's any questions that you had, I could speak to any of my spine colleagues or neurosurgical colleagues. But yeah, that's it. So thank you very much, and I'll see you at the next lecture.